When I sent people to the dietitians, people would come back heavier than before. Everybody goes into nutritional ketosis when they don't eat for 2 days. How can this be bad for you? Think about it. We store fat on our bodies to be what happens when there's no food around. There are anti-inflammatory mechanisms happening when you're not having to deal with the stress of eating. Cholesterol is so important, every cell can make it, and it's not easy to make. And the less of it you eat, the more your body makes it. What does the LDL do? 9 out of 10 times, the doctor can't say because they've never been taught. Good food is medicine. Bad food requires medicine. The more carbs, the worse off you'll be metabolically.
Welcome. Today, Dr. Burr is not around. He's on a plane right now, so he won't be able to join us. However, we have a pre-recorded interview with Dr. Eric Westman, Associate Professor of Medicine in Duke University and past president of the Obesity Medicine Association. We discuss a lot of stuff, including the misconceptions from standard medical care regarding low-carb and ketogenic diet, plaque evaluation, cholesterol, aspirin, and a bunch of other stuff that you don't want to miss. This is a terrific interview. We have plenty of stuff for you to share. Just want to remind you, click the like button, subscribe. I'll be answering questions on the chat as we move on live. And at the end of the interview, I might answer a couple of more questions and then hype the next week's show for you. You don't want to miss that one either. Without further ado, let's go ahead and show the interview with Dr. Eric Westman.
To be with you. My name is Dr. Eric Westman, and I'm an associate professor of medicine at Duke University in Durham, North Carolina. I've been here since 1990, when I came as a general medicine fellow in 1990. My prior training, I was an undergraduate at Stanford University, and then did my University of Wisconsin Medical School training in my hometown, Madison, where I grew up. My internal medicine residency and chief residency was done at the University of Kentucky in Lexington, and then went to Duke in 1990 to do a clinical research fellowship, which actually was the beginning of what was called evidence-based medicine. So I've always been a, where's the data kind of clinical person. Although my early research was done in smoking cessation, doing clinical trials. I met and have been collaborated with the inventor of the nicotine patch, who still is here in Durham, North Carolina. And so we did the early nicotine patch studies. I was pretty much known as Mr. Randomized Controlled Trial. And so in my early days at the Durham Veterans Affairs Medical Center as a trainee learning evidence-based medicine, they required us to be in the clinic and to have a clinical practice. Some fellowships allow you to just be in the laboratory or work with animals, that sort of thing. This general medicine fellowship required you to be in the general medicine clinic at the VA, called ambulatory care. So 2 of my patients in 1998 or so lost over 50 pounds each. I didn't tell them what to do. In fact, when I sent people to the dietitians, people would come back heavier than before. And it turns out I was kind of a prevented-minded internist, which is sort of an oxymoron. Most internists aren't prevented-minded. But so when these 2 people lost weight in front of me in my general medicine practice, I took note and said, what did you do? And they both did what at the time was called the Atkins diet. And fortunately, people under the age of 30, 35 don't know anything about it. But if you're over the age of 50, 55, you immediately think, oh no, not the Atkins diet. Well, fortunately, or just the situation was, like most doctors, I received very little nutrition training. I received a little bit of total parenteral nutrition training in internal medicine residency, but this is done in the ICU when people can't eat or drink, right? So my naivete about nutrition was very helpful, because I just said, wow, this worked, the Atkins diet, sure. So went to the bookstore, wrote Dr. Atkins a letter and said, what's going on? He calls me on the phone and says, what do you want? I said, well, 2 of my patients lost weight on your diet. And he says, yeah. So, and I said, well, where's the data? Where's the research? Looking back now, 25, 26 years later, there was never a study that showed the Atkins diet was bad. Never was. In fact, Jeff Volek and I did a mild review, mild meaning there just wasn't much data. So the first thing you do is you do a research review. And there were 5 to 6 papers saying it looked good for, a month or two. But the onus of the burden I felt then, I don't feel it so much now, but everyone else still does, was to prove that it works. I mean, so Dr. Atkins said, I know it works. Why would I want to do research? So I thought either he was in it for the money, like all my colleagues thought so at the time down here at Duke, or maybe he knew something. So it was Dr. Atkins who said, why don't you come to my office and see what we do? So I went up with a 2-member research team with a proposal to study what he was doing back down here in Durham, North Carolina. I went and sat in the office, and it clearly worked, unless, as my colleagues back here at Duke said, they said they probably hired Broadway performers to come in and pretend to be clinical patients. And I thought, okay, that just wasn't, but the disconnect was that strong. That he has everything to lose. Why would he want to do a research study? Well, years later, I hear no one had ever asked him to do a study, and he wasn't a researcher. He was a clinical guy who read the Journal of the American Medical Association paper on low-carb diets and started implementing it. So in his mind, he was reading research that was published and implementing. Anyway, so there was a paper in 1980 with 24 people, non-randomized, people lost weight, and the LDL went up 10 points, and they said that, look, it's killing people. So now, and it's taken me 25 years to say everybody goes into nutritional ketosis when they don't eat for 2 days. How can this be bad for you? Think about it. What phone company would make a phone that says low battery? Should I go into self-destruct mode?
That's a great analogy.
What evolutionary pressure or clockwork God, I don't care what you believe, would allow for nutritional ketosis, fat burning, we store fat on our bodies, to be what happens when there's no food around? If anything, what's being found is that there are efficiencies that are made. There are anti-inflammatory mechanisms happening when you're not having to deal with the stress of eating. I mean, but this took me 20 years. I'm an old paradigm doctor who, was taught Atkins was bad and eating fat was bad, and when your cholesterol goes up, you're going to die. And so one by one, as the years go by and these things aren't happening, I'm starting to rethink pretty much everything I know using the number needed to treat, evidence-based medicine, the idea that you can actually talk to a patient about personalized risk. And now what I'm really struggling with, and I would like to have you help me with, is the personalization of medical care, where lifestyle is a very potent intervention. And yet most other doctors only understand medication. And so my patients are being pressured to take medication when they're doing a very powerful lifestyle intervention that, in best, I can take someone off 10 medications in the right, if they're diabetes, high blood pressure, arthritis, heartburn, GERD, migraine, so I practice the best internal medicine of my life without medication. It's just by changing the food. And what doesn't compute, and why I can't go to the American College of Physicians, I used to be a member, is that, it's not a medication. I don't think anyone's going to care. Now, that might not be true, but so I gravitated toward the Obesity Medicine Association, which is a group of doctors who have thought obesity is a disease for the last 50 years. and I'm past president of that organization. So I learned and taught a low carb sort of approach within a doctor group. Since we let PAs and NPs become certified within the organization, now there are a lot of PAs and NPs in the Obesity Medicine Association, and I go to that meeting every year, twice a year if I can. But even then, I'm left with, you don't need to be a doctor to teach someone how to eat. And if doctors don't have the training, and so I'm helping start a new organization in the last few years. The new organization is Society of Metabolic Health Practitioners. So much like when there's a hurricane, you need to train relief workers to go in and clean up the mess. You don't need highly trained people to go in and build home. You know, we need people to come in and clean up the mess. And kind of like Weight Watchers did, you can have super users of low carb diets teach it to other people as prevention or even as treatment, but you need the doctor to help get people off the medication, I believe, safely. But anyway, so now I'm on the board, founding member of the Society of Metabolic Health Practitioners, with that idea that we need to train people now. The epidemic is here, it's real. And we can't train, 10 really highly qualified people. I mean, so telling you how not to eat carbs doesn't require me to know how to do an operation. I'm I'm too I'm too trained.
As a matter of fact, you might have better chances getting some good dietary advice from somebody that's not a doctor than actually the dietary advice that you get from doctors. I can tell you, I mean, I think you experienced kind of the same thing as I heard. My training on nutrition on med school, I'm talking about maybe 10 years ago, was like 6 months of it. And it was supposed to be one of the biggest on the standard. It was actually 6 months. And I learned low-fat diet. That's what I learned. So it's actually impressive.
The army of low fat, the troops have been mobilized over the last 20 years through organizations like the American Dietetic Association, but because so many people were using the term nutrition, they changed the name to the Academy of Nutrition and Dietetics. But I even handed a zip drive with all of the low carb studies to the research director of the American Dietetic Association years ago, saying, look at these. I'd never heard anything back, but at best I can tell, they're trained in that one size fits all method, which clearly hasn't worked. I mean, by anyone. Now it can work, and that's where it gets confusing for folks. How could my brother eat all the carbs and not gain weight? It's true. And me, I have the same food intake, and I'm the one who stores it really well. So, that's important to be scientific about this and not advocating only one way to do things, which has done a disservice. I mean, I saw Dr. Ornish through the years go from being the only one doing a study on lifestyle, which is great. Putting this on the map is great, but then he said everyone else was terrible. He even kind of yelled at Dr. Atkins at this great nutrition debate, which I was there actually in the audience with the research data. And so a disservice that he has done is to say that there's only one way to do it. And the kind of, it's a bit arrogant actually to insist upon having certain criteria of a study level when you're the only one who's done the study. So anyway, I'm an evidence-based medicine guy. I know you don't need a randomized trial. If you have meningitis, everyone dies, and you give penicillin, you don't need a randomized trial. For vitamin C, they needed 12 people to show that vitamin C would fix scurvy. So, when you have a program like this or one that takes away the junk foods, basically the ultra processed sugary foods, you don't need many people. With 50 people in a study, we randomized people to low glycemic and low carb and got a spread of 1.5% A1C difference in 6 months. So when you're looking at things that are this strong, you don't need a whole lot a lot of data, and I just wanted to get back to the numbers. And yes, that's important, but there has been a lack of funding for lifestyle in general, and the reason is the NIH, the mission is to find the mechanism. And so I have the ability to change certain diseases, and I go to the world's experts and they say, well, that's fine, but we want to find the genetic cure, so it doesn't matter what people eat. So people want to give the medicine to the stem cells to fix diabetes, pancreas, when you could just cut the carbs out and the pancreas has enough function to be able to not have diabetes anymore. So anyway, my story is that I was funded by research entities, and then kind of just because it was so hard to get the funding, and just went into clinical practice. So I opened a low-carb practice at Duke University in 2006. I've been treating people. I just decided, well, I'm just gonna just treat as many people as I can, learn from it. And I've treated people with LVADs, which are the left ventricular assist devices. Their heart failure is so bad they need a heart transplant. And the heart transplant doctors are saying, well, we don't want to operate on them. They're too sick. We don't want to give them medicine. Why don't we send them to Westman, and he'll do that keto diet. And so if I can get one person to transplant, it basically pays for my program for the year. I mean, I have to imagine. No one ever comes to me and says that. But the surgeons love the clinic because I can get the slim people down, and the outcomes are better after knee replacements and hip replacements, and the reversal of diabetes. It just seems like nobody cares, but patients do. So that's and finally now there are there's a young professor and a med student now are querying our data, looking at all the people that had heart failure, for example. There's a research study being formulated around that, just a retrospective review. Another one looked at kidney function because everyone's worried about high protein in kidney. And so a young professor looked at our data, clinic data, and no, there was no major progression of kidney disease. So having done investigator-initiated clinical trials, I wrote them myself. I wasn't one of these pharma researchers who just kind of take the protocol and implement it. We actually wrote the grants that we did. Now, my colleague Will Yancey at Duke and the VA in Durham did a few studies within the VA system. And these folks it's not just generally healthy people coming. These people have a high rate of diabetes and other problems like metabolic syndrome. And so Dr. Yancey carried the research into that clinical setting as well. But I guess the shining star of diabetes research now is the company called Virta Health. And they've actually made a company wrapped around a Bluetooth scale, a Keto Mojo monitor, and talking to the doctor in the app. And Virta Health published their data of a control trial where they could reverse 70% of people on insulin, got off insulin by a year, compared to nobody in the control group. And now that company has made good headway in partnering with insurance companies and even some VAs. But it's a high-tech solution. What I do is I hand out a piece of paper, and so you have to understand that there are more ways to implement what Virta does other than their high-tech solution. But to be profitable, that is one way to do it. So I'm happy teaching and training in my clinical program in the Obesity Medicine Association, the Society of Metabolic Health Practitioners. And it is pretty amazing that the medical world is so siloed that we never overlapped.
Yeah. You are right. It struck me early on in this discussion. I hadn't seen it quite so much during looking at your content, but during this discussion, you're not your typical internist at all. as I mentioned earlier, I used to run the program training doctors in prevention at Johns Hopkins. And I can tell you, it's very, very different breed. For example, this focus on evidence. Now you see a lot of that with internists, but then focusing more and more on data. And then when you start saying, I don't need medicine, and in fact, I don't even need to be a doctor to cure patients, that's where you part company with
Well,
internists completely. And that's what you see in the preventive medicine community. We recognize being a doctor is often takes you in the wrong direction, because you're the only person with a license to write scripts. So everybody comes to you for prescriptions and they assume that's your power. It's not.
yeah, the power is in the food. Well, 100 years ago, and this is, I love learning from patients, and I'm still learning from patients today. They'll watch the YouTube, come in, tell me the next week, here's the answer to what you said. It's great. One of my patients was a used bookstore owner, and right when I was getting some flack for my first study of the Atkins diet at the VA in Durham, I get this book in front of me. She was a used bookstore owner. She said, Dr. Westman, I thought you might be interested in this book. It was the Osler Textbook of Medicine from 1923. And I opened it, it wasn't in great shape, but I opened it, I wonder what they thought about obesity and diabetes in 1923. So this, is 80 years later, roughly, and they used a low-carb diet in 1923. Insulin was discovered in 1921, and it didn't even make it into the Osler textbook, this edition. And so I was reassured, and showed that to my friend who was on the research committee, and said, why is the hospital upset I'm doing a study on this? It's been around for 80 years. So, but it had fallen so far out of favor. And then, like you said, the prescription being the answer for, and the doctor having the sole control for that. But it's not really the most powerful thing.
Definitely. And
Medicines.
I'm sorry, go ahead, Dr. Bruce. No,
No, go ahead, Aziz.
I was gonna do a segue, and you just messed up my segue, as you do. Talking about books, you had your own book, End Your Carb Confusion, a simple guide to customize your carb intake for optimal health. And confusion is the right word. We just recently started exploring what carnivore diet is, what keto diet is, what proper human diet is, as Dr. Berry describes it. And Dr. Brewer and we came to a conclusion. I always push Dr. Brewer on decide which diet you're on. Are you a low-fat guy? Are you a keto guy? What is it? Take a stance, for God's sake. And
I'm clearly a low-fat guy. I mean, I'm clearly not a low-fat guy. I was for like 30 years, but I'm not now.
We're basically low carbers, both of us. I mean, Dr. Brewer is my sensei over here, and we're basically omnivores. We eat a little bit of everything, but processed foods. That's the only poison we avoid. Can you give us kind of a summary what people will find out if they go ahead and read your perspective on End Your Carb Confusion book?
Yeah, so I teamed up with a professional writer and an author in her own right, Amy Berger, and our award-winning book, we got an award at a keto conference, End Your Carb Confusion, basically lays out 3 different carb levels. The initial carb level would be known as a keto diet, under 20 total grams per day. It's always total, not net. Net gets you basically just more carbs. Some of the subtracted carbs out of that net are actually absorbed and alter the blood glucose. So always total carbs. And then the 50-gram level and then 150-gram level are in End Your Carb Confusion, where you learn to match your metabolism to the type of diet that we think you might start with and just see how you do. So it's always a trial and error sort of thing. The 20-gram or less keto level of End Your Carb Confusion is basically what we studied in our clinical trials. At Duke, we started randomized trials going back to 2004, 2006, 2008. We published papers on that level. Dr. David Ludwig has done studies of low glycemic diets, and that's basically the 50 gram to 150 gram per day carb level. And of course, the foods that are involved, the food lists, are real foods. They're vegetables. They're non-starchy vegetables. You can start to have fruits and starchy vegetables on the higher carb levels. But what we teach and carry forward really is what's been known in the low carb world for the last 50 years, that there are several levels of carbohydrate that are consistent with healthy living, and it doesn't matter if it's ketovore or carnivore or you know. So I see the low carb world be subset now based on brands. So it's like we have all these cars, right? Cars. Some cars are autonomous driving, some are stick shifts, some are different colors, and some have different types of engine. So there are different types of low carb diets. And so a carnivore diet is a subset of low carb diet. And so it's not my first line of defense or my first thing I lead with, but I might let someone drop the vegetables after they demonstrate some sensitivity to them. But I don't lead by saying you have to be carnivore or you have to be plant-based, I think I think we are more omnivorous, although some people are sensitive to plant matter. And that's what's bubbling up in my clinic is I do a YouTube saying, I'm not totally against the carnivore diet. And then people end up in my office the next week telling me their story of how they've been picky eaters all their lives. And they finally figured out that it was plants that made them sick. Mm-hmm. In fact, one of my patients ended up writing her own book after she was in someone else's book about how she ended up in an anorexia nervosa ward. They thought she had something wrong with her brain, and it was all in her gut. It was that she was having trouble eating plants. So these remarkable transformations, to me, are kind of not what I lead with. So I come teach about what carbs do. They raise the blood glucose. They raise the insulin. It's that glucose-insulin multiplicative product, the product of them together, that is insulin resistance, as we can measure it. And so that gets better when you cut carbs down. And, so the science basically has said this is therapeutic. We can reverse all these conditions. What the science needs to catch up with now is the people who are using this for prevention, because we don't see the same chronic medical issues if you don't eat that level of carbohydrate. Yet there might be some other issue that happens that we need to know about. So the grassroots change about people doing low carb has led to conferences and Facebook groups and Instagram, all these people who have found that they can be healthy as best as they know by eating very low levels of carbohydrates. And the science has gone a certain way, but the clinical use of this is way ahead of the published research. And if you're interviewing people who think they have the even better diet, then show me the data. If I see someone improving and going in a certain direction, I want to just keep measuring everything we can. And now that I have a lot of people on low carb diets for a decade, the major concern, of course, that the mainstream folks have is atherosclerosis. Even the LDL level might go 2-3 times what is thought to be optimal. So I've advocated going to measuring the arterial system directly, getting away from just the cholesterol measurement. I teach my patients that cholesterol is not a disease. At best, it's a marker for atherosclerosis. That's the disease we're trying to prevent. So I'll say to someone, do you know if you have atherosclerosis? And it's much like these TV commercials you'll see where, how is your heart? And well, I think it's good. And then they have an EKG they're selling, the electrical system looks good on the EKG. How do you know what the narrowing or not, or whether you have atherosclerosis? That's the ability to measure now with ultrasound or with CAT scan has advanced so much, and it's still a little cost prohibitive, and it hasn't gotten into the insurance payment system yet. So I'm afraid that those who can afford getting those tests will get them. One of my patients flew to another city where he could get a coronary CT angiogram and pay out of pocket for it. And then the next patient I see who is from inner city Durham is not able to get that. So getting access to this information is that grates against my sensibilities a little bit. I'd like to be able to have this, but the ability to get that information has a cost to it. So again, my thinking is lifestyle change is really a powerful intervention. And so when my patients come in saying, well, I want to do something to prevent my atherosclerosis, I said, you already are. And you don't need to be on this medicine even until these medicines are proven to be safe and effective among those who eat low carb. They might even be harmful. So, it's almost like I'm protecting a tribe of people to, don't start pushing medicines here. And I'm really worried about reducing an essential compound in the body called cholesterol. Having written a course on cholesterol now, I have a company that sells courses, the Adapt Your Life Academy. Cholesterol is so important, every cell can make it. And it's not easy to make. And the less of it you eat, the more your body makes it. And so my internal medicine colleagues who think the only way to reduce metabolic risk and heart risk is to don't worry about what people eat. Let's just drive the cholesterol down and get the LDL under 30, which is, so what I coach my patients to say, if you want to be a little bit of a needle in your doctor's side, ask them, what does the LDL do? And 9 out of 10 times the doctor can't say because they've never been taught that the LDL carries around fat-soluble vitamins and fats in a bloodstream that's water soluble. And if you don't have cholesterol, you don't have LDL, you abort as a miscarry. So anyway, it's really kind of this Frankenstein-like approach that and just one size fits all. We all know that there are more ways to do it, except many guidelines and many mid-level practitioners who just follow guidelines don't have the breadth of understanding to realize that there's another way to do it. And at the same time, I'm not saying keep your head in the sand. I'm saying we measure what we need to measure along the way. But so I wonder, in your experience, how do you handle the questions about the blood and the atherosclerosis, or if you want to talk more about the type of low carb diet, we can, but essentially there are keto levels and non-keto levels of low carb diets. And I think a lot of the benefit comes from the lack of sugar, the lack of the glucose rise, the lack of the insulin rise. And that can be accomplished by plant-based or animal-based or omnivorian types of inputs.
So thanks for asking. A couple of things that I've thought about as I'm listening to you. One is, in terms of the low carb world, I've tended to be more at that David Ludwig low carb level as opposed to keto. I have a lot of patients on keto. But after talking with Ken Berry a couple of months ago, I got more interested in carnivore. I did a trial on lower, more of a long-term, as in 2-month trial on lower carbs. And guess what my LDL did? It always has been fairly low, 50s, 60s. It doubled from 55 up to 110 and then went up to 180 the second month. So,
good, you need it. Good.
Yeah. So we had Dave Feldman on a couple of times and Nick Norwitz. And so we actually have done a video criticizing Dayspring and Atia and all that crowd for wanting to beat down LDL. We've never wanted to do that, at least not for the past decade and a half.
Well, I think it's important to wait on that discussion until new data come in.
And it's coming in very quickly.
Well, it's good that you're talking to those people, and really the ones with the most clinical evidence, the practitioners who've been in it as long as I have, are the Doc Muscles, he called himself in Surprise, Arizona, Adam Nally. Adam has been using low carb Atkins type diets for over 20 years and measures the carotids routinely in his practice. And he's been saying reversal for Asia, and I'm like, well, we need to write it up before I can say it. And so anyway, Adam Nally would be someone to talk to. Dr. Sue Wolver, who's at Richmond, is in the university setting there. And it's kind of classic, though. There aren't a whole lot of university clinicians or researchers involved, because they're like people predicted 15 years ago. They've been purchased by companies, pharma, basically. I mean, the ones who can do that expensive type of research aren't the ones in the trenches in the clinic.
It's interesting. Having been an epidemiologist at Hopkins, you would think that I would jump on that. I have done plenty of research and was in that publish or perish world. I still see a major role for it. But I have to tell you, I mean, I wrote my own book, and I'm sure you haven't read it, probably haven't heard of it. It was about why stress tests don't predict heart attacks. And it went very deep into plaque evaluation. You've mentioned to me a couple of times, well, I should do more of a deep study on CIMT. Tons and tons of work has been done on CIMT. I don't really see a major long-term future in our real world because of CT angiogram. It does have significant advantages in that there's zero radiation. It costs $200 to $300 as opposed to thousands. And it really gives you a lot of quick and easy access to information about what's really important, and that is soft plaque. Now, unfortunately, there's a big issue with CIMT in terms of getting the interrogation, the technical way of looking at the plaque. That's a quality issue. There's a very big garbage in, garbage out component to CIMT. You don't have nearly so much of that with calcium score or with CT angiogram. But again, both of those have their own issues.
How about just, so the internal medicine residents at Duke are being trained in POCUS, where, the point of care ultrasound. Okay. And I thought by now an internist would have the ultrasound on the wall and just use it like the OBGYN doctor. I was carrying around an echo on the ward in 1990, thinking, we'd have these everywhere, and yet some doctors have them, but most don't. So could you screen with just a off-the-shelf, off-the-wall ultrasound?
I do know a bunch of guys who do something very similar. The difference between CIMT and ultrasound is one of the analytic processes. Ultrasound is, you're reading it with the naked eye, so you're not able to get really fine levels, as in tenths and even hundredths of a millimeter, whereas you do with CIMT. CIMT involves a more taking the data back, putting it into an IT analytics. And so that's, I think it's interesting to think about using in-clinic information with.
Well, so my training in operating characteristics of tests, if you have a very sensitive test and it's negative, it rules out the disease. That's snout. If you have a specific test and it's positive, it rules in. That's spin and snout. So if I don't really care about the total accuracy of this first test. If someone comes in, they're doing keto for 10 years, their LDL is elevated, and a very sensitive test says there's no disease there, that to me, that is very informative. That, or even if someone's 70 years old and the doctor says you need a statin because your cholesterol went up, and you never ask the question if they have disease or not, you may be treating someone who has no disease at all. What are you trying to do? Prevent a disease that they don't have after 70 years? They don't have the
Or even
genetic
worse, treat a
defect.
disease with medications that have very significant side effects before confirming that they have a disease.
Well, so the metaphor that I work with sometimes is a cancer doctor wouldn't give you chemotherapy unless they had tissue diagnosis of cancer.
Exactly right.
And so, but we just give cholesterol medicines willy-nilly, whether or not you have the atherosclerosis or not. That's crazy, really. I mean,
It's very crazy, and we don't
it's
recommend that.
indefensible.
We don't do that.
Yeah.
It's indefensible. Well, I
well,
mean, it depends on how you define indefensible. The vast majority of people do it.
well, but that doesn't mean it's optimal, right? It's
It's
malpractice.
clearly not optimal.
Malpractice is that you're outside the typical
Right.
practice. You might be doing the best thing and be accused of malpractice. So cholesterol is not a disease, and measuring the plaque in some way, I think, is important, but we don't want to use tests that are not helpful, or they may be too expensive. I mean, what's the role of the coronary calcium score? I talked to Phil Ovadia recently, a cardiothoracic surgeon, with his book called "Stay Off My Operating Room Table." And it's interesting, there's several cardiothoracic surgeons who flip and go keto or carnivore.
Right.
And so what Phil says is, Dr. Ovadia, is that the CAC score should be the mammogram of the heart, and everyone should get one. And yet a good friend of mine, Zoe Harcum, who's in the UK, does some great dives into the literature, and she recently did a kind of health services research level view of mammograms, and actually the burden of the false positive is pretty high. So that when you look at an entire system, she actually concluded she didn't want a mammogram, and so now Dr. Ovadia is saying everyone should get a CAC score. And I'm like, no, I don't know. Anyway, it needs to be formally evaluated. But if a CAC score is 0, the MESA study pretty much says even carb eaters are at very low risk of an event over 10 years, right? That's my read of
Yes.
that. Sure.
So a couple of points about that. I think we've had Phil on board. We're a big fan, and I would agree with you. He comes from a surgical perspective, not quite so much a perspective of looking at the predictive value of the positive test and the predictive value of a negative and the real purpose of screening. I have to tell you, listening to you, I have to agree that it probably is analogous to calcium, to a mammogram, even including the error problems with mammograms, because here's where the errors occur with a calcium score. You can have soft plaque and it does not pick it up. And there are folks that do stuff similar to what we do, recognize that, have looked at it, and have shown exactly that. The Standards Committee for the American Heart Association has said, you don't need to take a statin if you have a negative calcium score. We recommend doing something a little bit better, like a CIMT. And again, as we mentioned a minute ago, we don't recommend a statin unless you have plaque. So very, very different from the rest of the world out there.
What about if someone has disease, but they're doing an intervention that we think is as potent as a statin? And that actually comes, so a low carb diet in the hands of Virta, they're looking at the inflammatory changes, and basically it's more powerful than a statin, the anti-inflammatory.
Much more powerful. You do head-to-head controlled trials, and lifestyle management is way more powerful than any medication at all. Hey, Jesus, I'm sorry, you were getting ready to say something?
Well, I was going to say, just Dr. Brewer, for talking about confusion. I always get nervous when you say statins and you don't say low dose statin,
Right.
because that's part of the deal. Anytime Dr. Brewer mentions, statins can be helpful to decrease inflammation, they're looking for the advertisement and the sponsorship and where's the money coming from. That's not the case. And I think Dr. Brewer is talking from his own experience, but also from the research that has shown that low dose statins and even high dose statins can decrease inflammation. However, as Dr. Brewer said, I just want to be very clear on that. I don't think we ever have said, hey, and compared to main guidelines for cardiovascular preventions out there, statins are nowhere near to be the landmark of the pillar of treatment. It's just an add-on that we suggest for some people on a low dose if they can tolerate it, if they don't have side effects, because lifestyle is way more important by 100 times. And the other aspect we acknowledge is stents. And Dr. Brewer has it's part of the book that he wrote about how people will have a false sense of security getting a stent because they found plaque either on a calcium score or on a CT angiogram. They go through the cath lab, they get a stent, and they think, well, I'm done. Let's go back to the jelly donuts. And 2 years later, the stent is blocked back again, and they're having a heart attack, right? We covered a recent study that showed that stents could prevent heart attacks, but when you see the details on the study, it was clear. People who developed, who had a stent, and that did not develop a heart attack, they still can build plaque within the place of the stent. So the risk was not necessarily because of the stent, there was something else. And a lot of those people were doing a healthier lifestyle that they were used to do, what we call the healthy user bias, right? So yeah, Dr. Brewer, I just wanted to bring that out.
Yeah,
Well,
thanks.
I'd
So
like to-
let me clarify something, Eric. You and I haven't had a chance to talk about it. We do not recommend beating down LDL. We don't recommend worrying about it. We do test for it when we do our lab tests, and we do
How
counsel
about the
patients.
size, the LDL size?
What about
The
Or-
LDL pattern B
yeah,
versus
to me,
A.
to me, one of the most important ways of gauging how much metabolic disease someone has is to look at the impact on fractionation. So yes, we don't think that. I personally also don't think that small dense LDL is really the bad actor quite so much as it is a bioindicator of loss of large fluffy LDL.
Yeah,
But
I have to agree. I mean, having looked at health, so I even dropped someone from our earliest RCT because the LDL went up too much. Now I would congratulate them, but I was looking at NMR lipoprofiles or the VAP test, the subfractionization for years afterwards, and not all the low carb people following low carb diets had totally clear absence of small LDLs, and so the blood doesn't follow the perfection that we want, which means it's all large and light and fluffy. It's more complicated than that. The VLDL and the triglyceride have always correlated highly with metabolic syndrome in that construct, and then with insulin resistance. In fact, it was Dr. Atkins who told me in the first study, 2002, single arm, 50 people over 6 months, published the paper. He said, put triglyceride and HDL in the outcome figure or table. And I said, I don't know this. He said, no, put it in. He was so far ahead in terms, he was following Jerry Reven and insulin resistance. So the triglyceride HDL ratio is important, but HDL keeps going up over time. And doctors don't know what to do with this. And I'll see people routinely with HDLs over 100. And
we do too.
Like it doesn't even count. No, it does. And but even then, we got to look at the pipes. So I kind of dumb it down to how are your pipes? I'll even open the drain in the office, go, the sink, and say, well, it looks like it's flowing, but do we really know? Or is there any blockage? And And if someone's otherwise sedentary, they're 80 years old and they're happy, I don't think we need to know about the pipes. So this is where the personalized medicine comes in, and why I can't make a decision through YouTube. And I'll go to the Mayo Clinic statin decision aid tool and show the NNT and the change with high dose statin therapy. So I don't know the nuance of that, but I want someone to just realize that, okay, it goes from 6% to 4% if I take a medicine, my risk. And most people look at that and say, I'm not at high risk to begin with. So most people are being taught by a guideline that says if your risk is over 7% or 10%, it's worth being taught or treated, when they're getting a different treatment. It's called lifestyle.
Yeah, you mentioned to me early on about statins, saying, well, maybe it's okay if somebody's still taking the poison, meaning the carbs. And I would agree with you. Statins, for the most part, especially high dose statins, are for people that aren't going to really treat their cardiovascular risk. The real treatment is lifestyle.
That falls into Rob Lustig's statement, which is great. Rob, being the kind of bombastic fructose emeritus professor at UCSF.
I know him. We had him a couple of months ago too.
So it took me a day to get him to say sugar when we were working. Just say sugar. They don't know what you're talking about. So anyway, he still says fructose, but he'll say, good food is medicine. Bad food requires medicine. So that would be the diplomatic way of what you said, which is if someone chooses to eat carbs, you treat them. But a lot of people, it's not a choice. They're just frankly addicted. And until you wake them up and to that, most people with type 2 diabetes have sugar addiction. I couldn't do without my bread. Well, come on. If you can't go without a food, this is called an addiction. So and most people who go for weight loss surgery have a sugar addiction. This has been documented in the Yale Addiction Questionnaire in bariatric clinics. So in the obesity medicine world, when we're dealing with people, BMIs of the average BMI in my clinic is 37. Most of these people are not in control anymore. And being out of the fat cells start sending out signals, feed me and don't exercise. And so actually the fat kind of takes over like a tumor. And this was all worked out in pre-World War II. It was called the lipophilia hypothesis, where the fat cells want to grow. And so they're going to send out the cytokines, if you want to call them that, hormones to feed me and lie on the couch. So the couch potato is basically there because the fat cells tell him, and he's trapped. And it's not because he's lazy. He's got no energy. And what's amazing is that a keto diet fixes all of that. I'm just shocked that pharma hasn't come to look at the patients in my clinic and check their blood to see the magic that happens. They can probably find the new hormone that no one else has looked at, because the old saying is the drunk looks for his keys under the lamplight, because that's where the light is when he lost his keys. So anyway, all of that, the energy gets better, the hunger goes away in 2 days on a carnivore, keto, low carb, LCHF, Atkins induction, South Beach phase 1, protein power. This is all synonymous. And it's the fad diet that we see fading away at the moment is the low fat diet. It's dying a political death, meaning nobody talks about it anymore. Did we ever promote that? Oh, I don't remember. Now the cruel joke and irony, and I coach my patients to just tell your doctor you're doing the Mediterranean diet.
Yeah.
And the doctor goes, oh, well, that's good. And they don't ever ask the second question because nobody knows what a Mediterranean diet is. Anyway, I just want the doctors to give my patients a break.
I was surprised to hear you just say the average BMI of your patient population is 37. I shouldn't have been surprised. You're the past president of the American Obesity Association. So
I'm in Durham, North Carolina. I had a 700-pound 30-year-old raised in Durham. I mean, we have Miracle Grow. It's called sugar and it's sweet tea. Well, insulin's really the Miracle Grow, but
yeah.
of course that guy didn't ever come back because it was like staring him in the face. The wall chart that basically says, here's what you eat, and the sugar is all combined into this little penalty box, red box at the bottom. But he had to walk sideways through the door, 30 years old.
Jesus,
So,
what do you think our average BMI is?
I'll say something closer to 23 to 24. The difference
That's
is
what I would have said.
the patients who come to
Low
see Dr.
20s.
Brewer are actually patients that already started the journey. We don't have many patients that are in the beginning. A lot of our patients already watch your channel, watch other YouTube channels. They know a little bit more about low carb and the lifestyle changes, and they just come to see us and say, what else can I do? And it has to do with the plaque evaluation, because I wanted to go there a little bit about the follow-up, because people ask this all the time. Okay, I've been doing a low-fat diet, or I've been doing a low-carb diet. I didn't know I had plaque, because we get that a lot. I didn't measure my plaque when I started the lifestyle change. So I went to get a calcium score and it's over 1,000. And they're like, what? I mean, isn't this supposed to be a healthy thing to do?
They're ready to jump off a ledge.
Yeah.
Well,
They're afraid they're getting ready to die.
Yeah.
well,
And we know better.
Well, that's I don't know the right metaphor, but if what you did before is what created it, you're not going to know. So you have to that's a snapshot, and life is a moving picture. We need to get a second test, right, before making any judgment about that.
And what we recommend is go ahead. I'm sorry.
Well, but they're faced with the information from all the other doctors saying it was that 6-month exposure to the diet that did it, when the 50 years of eating carbs and junk foods had nothing to do with it, right?
Exactly right. That is exactly right. Yeah.
And they don't know the difference between calcification and soft plaque.
Well, and that's a tough one, huh? I mean, what is your idea about aspirin? It's kind of an old treatment.
I think aspirin has been beaten up. It's interesting.
Just the baby aspirin,
baby aspirin has been beaten up because my group, the American College of Preventive Medicine, the U.S. Preventive Services Task Force, several others came out and said, oh, you know what? We don't recommend it for primary prevention anymore. And the authors at places like New York Times, they're physicians, but they don't understand what primary prevention is. And so they interpret it to say, well, don't use baby aspirin anymore. That's not correct. We never recommended baby aspirin for age. You turn 60 and you start taking baby aspirin. We only recommended it if you had plaque.
Yeah.
And so at that point, it's no longer primary prevention, it's secondary prevention.
Well, but sorry to interrupt. What do you call secondary prevention now? I mean, it used to be an event, right? So that.
Well, we're saying plaque is disease.
Yes, where are the data that just show the plaque measurement and large-scale studies showing we should intervene in a certain way? Do those exist?
That's an interesting perspective. I have to step back and think about that question.
I think we're in a new era, a new space, but I want to know, that's why I asked, where if you knew that the plaque without an event would respond to the event secondary. So in my mind, or at least in the 90s, 2000s, secondary prevention meant you had an event like a stroke, TIA.
You'd had
so you had atherosclerosis, but it got to a certain degree that it created a clinical event.
I would agree. That's been going on for 20 years. 30, 40 years ago, some people still argued about, in cardiovascular disease, do you have disease before you have an event? Yes or no? And guys like me would say, yeah, you have plaque, you've got disease. Others would
Yeah.
say, no, not until you have an event.
Well, I
Well,
think we came through a few decades of academics who were just really hard-nosed. I mean, like almost to the point of no common sense anymore. I mean,
yeah.
and uh, what so that, but I guess in theory you could have a total rupture of the wall to create a blockage that created an event. But I'm glad to hear that aspirin still is part of this, because the platelet activity and all it's making a clot happen. Uh, and yet there was in the 90s this whole, should it be a full aspirin or a baby aspirin? It was like
Maybe.
the whole, why not just cut the carbs, please?
Yeah.
Now with this
Exactly
perspective,
right.
eat the bad food, take the medicine, or cut the food, cut the carbs. So I hope I help some of your carb confusion. The more carbs, the worse off you'll be metabolically, I think.
And
That's
and if I can provide some nuance and another perspective to this, I'm gonna do my best. Dr. Brewer, you're free to interpret for me as you do. I think also depends on your lifestyle. And Dr. Eric just mentioned that on the very last phrase about cut the carbs. So it's not the same thing to find plaque on somebody who is on a SAT diet all the time still, and they just figure out that they needed a calcium score and that it was positive, versus the guy who has been on a keto diet for 10 years exercising and they found out they have a positive calcium score. Those are two different settings, even if the calcium score is the same number. It's way different. And I think if you are trying to provide aspirin or statins to everybody who is 60 years old and 60-year-old or older, just because you think they have plaque or they have risk, I think that's on one extreme of the position. And if you're providing aspirin once the heart attack has happened, that's just too late. And you need to consider that the plaque doesn't have to be big. You don't have to have plaque that is obstructing the blood flow to have a heart attack. I always say this, and Dr. Brewer gives me a hard time for that. Size doesn't matter. It's about the type of plaque. You can have a plaque of 25, 30% occlusion that nobody's going to place a stent on it. But it's a soft plaque, it's unstable plaque. It can rupture, and the clot can block the whole blood flow. So it's a matter of identifying where your real risk is. We presented a study where they showed people with a score of 1,000 on the calcium score have less risk of heart attacks just because that's a stable calcified plaque. But it matters how you do that. It matters how you build calcium in your arteries if you're building that. Of course, the best thing will be to have no plaque. But if you already have plaque, what you want to do is the calcium deposits to be homogeneous. So you have a thick cap in there that's not going to rupture, and you do that by cutting the carbs, exercising, and that's it.
Yep. Well, the world's we need to segment if someone has no history of heart disease, no heart disease in the family, there's no evidence of atherosclerosis. This is a different situation than if someone ends up in your cardiac prevention clinic having the disease already, having to make changes. I hope the internet is wonderful and terrible at the same time, because people can watch and assume that it's talking about them when it's not at all. So there's still a role for personalized medicine, going to talk to someone, getting a test if you're moderate to high risk. The CGM, continuous glucose monitor, has taken the management of diabetes out of the hands of the diabetologist, because the individual,
which is a good thing,
manage. Well, when are we going to be to the point where a person can measure their own plaque to take the management away from the cardiologist or the preventive medicine doctor?
We get beat up on this a lot, but we have a video. I did a video a few years ago, DIY plaque evaluation, and it was just a simple old ABI. ankle brachial
Yeah,
index.
sure. Okay.
But what happened was the topic itself is very, very popular. And so Jesus was coming back, cleaning it up, and we're actually redoing that right now.
Great.
Just so you know,
Oh.
Dr. Eric, nobody understood that video, so I had to write it down back again so Dr. Bird can explain it clearly.
Well, there's a company that comes around that does the carotids and the aorta, the heart, and it does ABIs. I recommend people get it because it's relatively cheap. You get a report in the mail. It's not hidden somewhere. And the reports I get through my radiology, it's uninterpretable. I mean, and even then, the ultrasounds now, if it's under 50, it has to say less than 50%. And so I don't even know if it's zero, which is kind of crazy. So anyway, I hope that that company is not like thought of in a bad way. It seems like it's a reliable. I go and get it done myself. This is the Lifeline screening company.
Yeah, I was just looking that up. So we work with a lot of people. The techs that actually, we work with a lot of people in the CIMT industry, and Lifeline says they do a CIMT. A lot of the
I don't think that. Yeah, no.
A lot of the techs come out and they criticize them a lot because they'll do some moonlighting there, and they say it's a cattle car. You push people through. Here's the
but again, my mindset is like the CAC score of 0. If the carotids are clean, the aorta shows no evidence. This is supportive of you following whatever lifestyle you're doing, and we'll follow it up over time. And it gives me ammunition, and my patients ammunition when the primary PCP across the street says you need to be on a drug for this elevated cholesterol level. They go in with their reports and say, well, I don't have the disease.
Right.
So, I mean, that's where I am kind of trying to innovate and improvise with this imperfect world of testing and treating. Let's see if you have the disease or not. If you do, then that just gets into the other management that I saw Dr. Ovadia and others saying you should have vitamin K2 and all these other things. And I'm like, wait a second. If you haven't tested these for safety, they might have in vitro or in vivo effects, but I'm not a vitamin guy to just push vitamins. In fact, I've never prescribed vitamin D in my life because it actually goes up as you treat obesity. So it's a different, I think I have a different context or a different clinical situation than your typical patient, but the overlap is great. And I hope I clarified some of the confusion that carnivore and the PhD diet, the proper human diet, of course, Ken's an MD, not a PhD. I think anyway, that book I'd like to see. I've spoken at Dr. Berry's conference that he's put on, and I put on conferences around the country pre-pandemic on Saturday mornings, talking to people about low-carb diets as well. So we both have a reach into the community, and having people come telling their stories at a place like that, it's really overwhelming. The positivity that, especially when someone's been searching for years for something to work. Of course, carnivore isn't the only thing that works, but it's relatively simple for people. The low-carb keto and your carb confusion approach allows for a little bit of vegetables, a little more flexibility. And yeah, you can do keto vegetarian. What I say is, if someone comes to me, I say, my materials really are more suited for the omnivore, but here's some websites. I connect people to Instagram sites in their country. If they want to do an Indian version, for example, of keto. So fortunately, all of that teaching is there, so it makes my life easier. And I don't have to have a vegan approach that the other people do.
So let me
aren't many vegans that come to me in Durham, North Carolina.
Well, yeah, but we get some of that, right, Doctor? We get some vegans,
yeah.
some plant-based, some carnivores. We get a little bit of everybody, and the main goal is, I mean, if we
And
have
we're
plaque, what to do
omnivores,
about
too.
it? We're omnivores. I mean, we share that. We're on a time stretch right now. I really appreciate your time, Dr. Eric. We both do.
Pleasure.
Just wanted to mention this, and then I'm gonna let Dr. Brewer address anything that's missing. We have plenty of stuff that we would like to invite you once again to come back and keep talking about all this, because it's this an infinite amount of information we can cover. We probably, I don't know if you're gonna be on the Low Carb USA meeting on San Diego this year. If you are,
Yeah.
we'll be happy to meet you there. We're gonna do a trip, and I told Dr. Brewer to stop being a hermit and start socializing
Yes.
with
Come
the
on out and
community.
play.
Yeah, so that's what we're gonna do. We're gonna be there in August. That's a small plug for the Low Carb USA. Dr. Brewer, anything that we wanna cover?
No, we touched on so many things and really didn't get that much time to, we're really pushed for time. I would like to talk a little bit more about, before we started recording, you started talking about vegans and low carb and some of the challenges in that space, and maybe some overstatement of things by some of the more prominent vegans. I was curious about that. We'll
Yeah.
have to bring you back to talk about that. We also,
Yeah.
I had a little bit more information about Lifeline. It's not that simple. It's somebody that knows screening tests and the predictive value of positives and negatives, like yourself, I think would understand a little bit better that when they get a positive test, that is very helpful. The concern is when they say you don't have disease, when the test is not that great, that can be a problem because somebody's laboring under a false sense of security. So
Well, so
there's a
then
lot
that
of
can be
stuff
that can be
we,
quantified by a sensitivity and specificity. In
yeah.
fact, that I was wondering if you'd ever seen a retest reliability of a CAC score. So, radiologists come up with scores and then they assume, well, this is truth. When
Yeah.
if there's a blood pressure study, we would measure twice. Carpenters measure twice so that they only have to cut once. So I wonder how close the CAC score is if you have the same test done. It's not something that someone who promotes the test would typically do. It's more of something a critic would do.
In reality, it's a lot harder to screw up a calcium score than it is a CIMT. But
Well,
again,
yeah, it seems
it's
like it's
another
more
topic
operator
for,
dependent. Yeah.
yeah.
Well, that's great.
So,
And let's continue to talk. We need to talk about the LMHR, the lean mass hyperresponder study. What you think about that? It's a great time for new data, thankfully. It's been a
yes,
while.
it is.
Yeah, we're anxiously waiting for that. And just wanted to give another plug real quick. Make sure to check out Dr. Westman's channel, Dr. Eric Westman, Adapt Your Life. If you haven't seen that, a really, really great channel to take a look at. Go ahead and subscribe. Dr. Brewer?
Past president of the American Obesity Association.
And the
Obesity
Society of Metabolic Health
Society.
Practitioners.
I'm sorry.
Yeah.
Obesity Society. I think most folks would know what I'm saying. You're very well credentialed and qualified in terms of helping people get off the biggest threat for health right now out there, obesity.
Yeah.
Extremely
Yeah.
well qualified.
Thank you for having me on your channel. Appreciate it. Podcast.
You're very welcome.
All right. So I hope you enjoyed the show. Thank you so much if you're still here. I want to give a shout out to RJ's $20 super sticker. Thank you so much. Those go a long way. And I won't hold you any longer. I just wanted to give you a little bit of hype regarding the last comment Dr. Westman made. So that article actually has been already published, at least some of the results. I don't think it's the full thing just yet, but some of the results have been published. And it's all about, is LDL and ApoB the cause of heart disease? And we want to cover that article. We're going to show that to you next week about the lean mass hyperresponders, those people who have high levels of LDL, but they're actually fit, low triglycerides, high HDL, Are they actually at risk or not? But we want to go the extra mile, and we want to show you both sides of the conversation. So next week, we're going to cover the evidence that's backing up LDL and ApoB. Why is there a lot of doctors, and why is the mainstream guidelines so keen on pushing down LDL and ApoB and thinking that's the solution? To their credit, guidelines also talk about lifestyle, but I don't think they do as much emphasis as they should on that specific aspect. So we're going to show you both perspectives. Why LDL and ApoB have a lot of responsibility on plaque, if that's the case, and we're going to show you the study of the lean mass hyperresponders and the other perspective on is there something else more than just LDL and ApoB causing heart disease? So stay tuned for next week, and we're going to cover that. Very interesting show for you. We have a couple of more interviews coming up. So subscribe, hit the like button, share, and thank you so much for joining us today. See you next week.